All right, now seriously, let's get into this. Do we have any new information, Richard? And again, Richard Roberson is the Vice President of State Policy and General Counsel for the Hospital Association, so the legal man can answer all these questions without any worry whatsoever. What's the status of that, or is there any change at all? Because there are a lot of people in the Delta area and our hometowns there who are worried about this.
Yeah, I'm assuming you're talking about the situation in Greenwood. Yeah. I don't have any new information to share other than what we've seen publicly, which is I believe the city and the county are trying to come up with the funds to help accelerate a deal with UMMC and the hospital, which certainly that is super important for folks in Greenwood. I've got
Hospital
family
Association,
up there. And,
You guys don't get involved in any of these mergers or anything at all as far as the association?
We do not unless we're trying to facilitate relationships and trying to bring people together to find solutions for it, but we're not involved in the transaction.
Could I ask you, as an attorney also, and I've asked this question before, and I think it's an important question, what percentage of the possibilities of these people shutting down are the ones who have shut down? It's just poor management. But, I mean, I hear a lot of people telling me, and when, we get off the air, sometimes I get more calls on any given day, but there are a lot of people who say they're just, in some of these places that have closed down, it's just not so much Medicare, Medicaid, transfer payments, insurance, all that's a pretty big part of it, don't get me wrong, but it's lack of people who work in the hospital, its facilities have been run down, and it's just poor management. So what percentage of this is that? Because I think it's a fair question. The people in those cities want to know.
Yeah, I think it's a fair question. I would submit that it's really a revenue issue. I mean, we see lots of business. You think about a lot of professional sports teams. They can be pretty badly coached or pretty badly managed, but they're not going out of business because they've got plenty of revenue. And what we're seeing from the hospitals, and particularly speaking to the situation in Greenwood, is they've got, I think last time I looked, about $4 to $5 million in uncompensated care. Their payer mix is primarily Medicare and Medicaid, which pays you right at or right below your cost. And their commercial payer mix is probably around 15%. And so that is a really challenging situation when you've got $4 to $5 million of uncompensated care that you just don't get paid. That's what it's costing them to provide care to people who aren't able to pay anything for their health care services. And, the business model for hospitals is different. They're required under federal law to provide care regardless of the patient's ability to pay when they come in through that emergency department. A lot of people come in through the emergency department as their gateway into health care. And if they can't pay, then it's just on the hospital. There's no other business that I'm aware of that is required to provide free care regardless of a patient's ability to pay and regardless of how many times that patient comes back. And so that makes it really challenging for all the hospitals. And I think in Greenwood and in other places around the state where you typically see hospitals close is where you've got that very difficult payer mix of a high amount of uninsureds, uncompensated care, and low commercial coverage.
But it doesn't negate the question that some people may have in the Greenwood area or any of these places where the hospitals are anemic. And the reason it doesn't negate that question is because you can have poor management, and the poor management could be because you have revenue that's not being collected. Prime example is in the Jackson water crisis, where there's no billing. The billing is all screwed up. It's not going out. The computing, the entire accounting process is messed up, and that goes back to the administration, and it also goes back to the staff, et cetera, et cetera. So those two things can be and probably are linked in some manner.
Well, they certainly could be. I've not seen, of that $5 million or so that Greenwood has as uncompensated care, I've not seen how much of that could be collected.
But that's a pretty big question, though.
Yeah, I mean, some of it could be collected, some of it may not be. So I don't know as far as that goes, but what I can tell you is that it is a difficult payer mix to work with when, Medicare, Medicaid are coming in at, 70% or so of your book of business, paying you right at or right below cost. The Medicare sequestration cuts and other cuts made under the Affordable Care Act made it really challenging for Mississippi hospitals. Greenwood, I think, last time I looked, was over about a 15-year span just from Medicare cuts alone, starting in 2012 through 2027, was set to lose over $60 million from Medicare. I mean, that is a tough that's a tough model to work with.
I seem to remember, and this is not a new problem. We've had this problem for a long time, actually decades. And I seem to remember that Barack Obama and Joe Biden, as vice president, were touting this as a way to save our rural. Obamacare is going to be the savior of local hospitals and your hometown hospital. And apparently it just made it worse.
Well, the cuts on the Medicare side were intended to pay for the expansion on the Medicaid side. Mm-hmm. That's how it was supposed to work. That was the kind of the model. And, of course, we have not accepted Medicaid expansion, and that's a whole different discussion. But, the cuts on Medicare were, under this kind of budget neutrality type of thing that they do in Washington. You cut one side and pay for another, so it all balances out budget-wise, and that was the deal. They cut on the Medicare side to free up money for the Medicaid side. Yep. It was a rob Peter to pay Paul type of model, and we've not paid Paul, and so that is the challenge in Mississippi. We've had all the cuts, but none of the pickup.
Really, the only transformative thing and it's not much transformative, that you heard from the Republicans in the last administration, and it was the president who wanted that transparency, and he felt like through competition, and by the time he didn't have really a long time to enact this because of all the other problems, and also for just one term, but apparently transparency did go into effect. And nobody knows it because it's not really that transparent. They've watered it down to the point where it's meaningless, and that is a shame because I think if he had 2 terms, we would have seen something on that one. And also, if they do get back in, House, Senate, and later on in the White House, they ought to come out with something that solves this, no matter how many pharmaceutical people they make mad. But we'll talk more about this with Richard Roberson. All right, let's get back to it live in the Trustmark studios. When it comes to online or mobile banking, all that power is at your fingertips. From Trustmark, people you trust, advice that works. Member FDIC, and in the House, Richard Roberson. Richard is the Vice President of State Policy. General Counsel, Mississippi Hospital Association. And we were talking about numerous different things, but the Medicaid expansion, will it come back up in the 2023 session? And if it does, as far as what you know, will it take the same form, or will it be rebranded, or a Medicaid expansion light, or what's going to happen in 2023?
Well, we're looking at all kinds of options to provide health care access to folks who don't have health insurance. In order to have a healthy workforce, you got to have healthy people. And so we believe it's important to do that for economic development reasons, as well as just your quality of life and for those patients and for the health of our healthcare system. It really helps when providers get paid for what they do. Yeah. No money, no mission. I don't think any of the hospitals, physicians, or nurses could do what they do without being able to get paid to do it. I think probably a lot of them would do it for free if they could, because they love doing what they do and taking care of patients. And in Mississippi, as I was talking about with the cuts on Medicare and its impact on Greenwood, across the state, from 2010 to 2027, the projections a few years ago that we were going to absorb over $4 billion in cuts from Medicare. And that's a combination of claims cuts and how they did that to the 2% cuts through sequestration, cuts on the uncompensated care program, which is DISH. And so, it's a huge impact on a state that is about 40 to 45% dependent on Medicare. And so all of that hurts. So we're looking at different options. Expansion would be one option that's been talked about. We're looking at other ways to go about doing it. So we're open for whatever ideas folks would have.
I would love to have this in a supercomputer and say what's the best idea. Let me play devil's advocate, and you play the counter on this one. The negatives of doing this, and just from the information and the people we've talked to here with this family on the air, the price tag from people like the insurance commissioner or others, and I'm not going to hold him to this one, but price tag I hear also from Medicaid is it would cost us as taxpayers in Mississippi, not the federal, an additional check to be written to put extra people on there, around $400 million a year. You can disagree with that in a moment or two, but let me finish it out. So it's going to cost us about $400 million of state money from our state treasury to put these extra people on. The other thing is, once you start putting people on at a higher income bracket, which is not that high, don't get me wrong,
right,
at a higher income bracket, if they are in that job, they have a chance to progress out of that job, and they would disqualify if they took this new job, and if it's not that much, would they do that or not be able to take that job because they would lose their Medicaid expansion money? That's another one. The other part of that is, the question is, with the people that are on Medicaid now, have they, and they've been on there for a while, generationally, are they healthier? So those are plain as the devil advocate on that side. I'll let you answer all of those.
Sure. Well, the price tag, I've never seen any model that's put the price tag at an annual cost of $400 million a year to the state of Mississippi. Typically, it's been out there at about $100 million under some changes that came in federal law a year and a half or so ago. That actually would get offset by cuts in what Mississippi would have to pay for its traditional Medicaid program, the program we have now. If we did expansion, there'd be a huge savings on that would more than offset whatever the state would have to pay annually for just the expansion part. So, and there's been numerous economic groups. The only groups that I've ever seen come out with a price tag like that would be some of your partisan think tank groups that would come out with stuff like that. But any independent analysis, economic analysis, it's nowhere near that, and the benefit is much greater than that. That'd be like me telling my boss, Tim, that I'm not coming to work today because a gallon of gas costs too much, and so I'm going to sit at home and I'm not going to get a paycheck because it costs me a little bit to put on a suit and gas up the car. Yeah. So that I think that argument really doesn't make any sense, and and we're poised to do something really big for the state of Mississippi today at the legislature, where we're going to make an investment in a company that's going to pay huge dividends economically, and that's just the right thing to do. If you're fiscally conservative, you're making deals that overall in the long term benefit your state, and expansion's really one of those. As for the people and how they progress in and out of that expansion population, it is for low income working people. If they never accelerated through their job, never advanced, I suppose they would stay on in expansion indefinitely until they got coverage somewhere else. Most people try to raise their status in life over time, and they try to do what they can to improve their quality of life and improve their financial conditions. So I would hope what this program would do is it would keep people healthier, allow them to work. For folks that may have mental health, behavioral health issues that go untreated now, it allows them to not decompensate to the point where they've got to have SSI disability. That has been one of the biggest areas in other states that have done expansion, is they've seen a huge impact on mental and behavioral health issues for people, typically low-income working adults. Maybe they've got kids in the house, maybe they've got other life stressors that get triggered when they've got other conditions, and this helps keep them healthier. Back pain, respiratory illnesses, and all those other things that folks get. Obviously, if they're laid up, they can't go to work. So hopefully this allows them to go to the doctor. They're not having to make a choice between putting food on the table for their families or their kids and taking care of themselves. And so that's the thing on that.
I would think one of the reasons there's a large gap in that number is because it is open for just the imagination. And I think in a previous interview, some of the stats were gained from other states who have done this. And they said, and they sold the goods to say we're only going to have 100,000 people, and it's never worked out that way. It's always been 200,000 or 300,000 people, or in other words, the amount of people that would be added in there, they've sold it at one number, and it's always doubled or more. So that's probably where they got the leeway to expand that up to $400 million. I'm not sure, one way or the other.
Yeah, could be.
The other question, too, and again, Richard Roberson, and Richard is Vice President of State Policy and General Counsel for the Hospital Association. How is our friend Mr. Whitwell, and I think Governor Musgrove is also, I'm not sure, I think he is also in the acquisition of some of this. I may have misspoken about that. But there are some people out there buying these hospitals, and apparently, like, some of they've turned out to be profitable. How are they doing it? Like the Panola Hospital or Batesville?
Yeah, so I think you're talking about Quentin Whitwell and what they're
Quentin,
doing.
Our friend Quentin Whitwell.
Yeah, and Quentin, and certainly their members.
So
of
what
the Mississippi
magic
Hospital
formula are they using? Because nothing has changed as far as the state or federal laws.
Well, so, what we've seen, and I think what Quentin's tried to do with some of his facilities, convert them to critical access hospitals, which get reimbursed on a different type of reimbursement model than your typical small rural hospitals. They get reimbursed a little bit closer, their cost base reimbursed, and so that certainly helps. I think that's what they've tried to do in Marks in particular. In Panola, I think they focused a lot on certain niche services such as mental and behavioral health. And they've offered some other services to their community and tried to put it together as best they can to make it float. And that's what you see a lot in our rural areas. If they're a critical access hospital, they're trying to open up rural health clinics, things that get them reimbursed closer to their cost, which helps them just kind of eke it out and make it work. So that's
the other big thing here. The hospital in a rural area today cannot be what the hospital was 10, 15, 20 years ago.
Yeah, well, and I don't think many of them are. The problem, like with the situation in Greenwood, is they are not able to convert to critical access hospital status because of the way the federal laws are written. And they're too big right now, so they've got to adjust to that as well, as do a lot of the other hospitals. But the main issue is just the revenue is not there in a state like Mississippi. That we've got the largest amount of medical debt.
Did you guys put Tim in quarantine? I haven't seen him for a while. Is he in quarantine? Did I make him mad or something?
No, I don't think so. I don't know what you said, but
apparently I said something else. He's just hiding from me. I haven't seen him, and I thought he was in quarantine or in Hawaii. I'm not sure.
I know he's not there.
Thank you,
Richard.
Appreciate it. You got it.
Thank you, Paul. Appreciate it.